So I'm Jill Harkavy Friedman. I'm the Senior Vice President of Research at the American Foundation for Suicide Prevention. And we're a national organization with 73 chapters around the country. And we fund suicide prevention research along with providing programming through our volunteers, advocacy. We have an office in DC and advocacy days in all 50 states, plus Washington, DC and Puerto Rico. And we also have support programs for people affected by suicide. So I encourage you to come to our website, afsp.org, if you want to learn more. What I'm here today to talk about is suicide and substance use. And the goal is that by the end of today, you'll be able to describe a model for suicide, for understanding suicide across the board, to be able to list contributors and potential warning signs, and also to be able to describe how to have a conversation with someone if you're worried about them. So when we think about suicide, it's multiply affected. There are many factors that contribute to suicide. A person probably doesn't have all of them, most likely, but they have some of them, and they're also quite dynamic in that they're, for instance, mental health. That sometimes you can be mentally well, and other times you might have a mental health condition. There are also, and also you'll see substance use in the left-hand side. Also, there are protective factors that are also working. So while you have the genetic factors of family history, the history of abuse and neglect, trauma, chronic health conditions, people also have resilience. They have access to care, they have support and the willingness to access care and the ability to problem solve using their social skills. So you can see how these things are dynamic. They're not constant, and they're always in motion. Now, when we see someone who's died by suicide, it's very easy for people to say, oh, they had a stressor, and that's what caused suicide. So it's important to know that most people have any stressor that you can think of that people who died by suicide had, but they don't take their lives. But in the background, they may have these contributors that may be contributing to vulnerability. So either in the face of chronic stress or in the face of more immediate stress, they might have an urge to kill themselves. And sometimes this urge is very quick, 10 minutes. But sometimes people have thought about it for years. What moves them from thought to action can also happen in very short time with urges. I'm going to talk a little bit more about that afterwards. But the truth is that the people who die by suicide also had access to lethal means. And that's what gets a little tricky with substances. And I'm going to talk a little bit about the overlap. Fortunately, if you don't have access to lethal means, you will survive a suicide attempt. Now, in substance use, we have the same variables in the background, but now instead of having substance use there, we have suicide risk as a risk factor. So you can see that there's probably overlap between the risk for substance use disorders and the risk for suicide. Again, these are all dynamic, they're all moving, and suicide risk is one of those factors. So I'm going to share a video, which hopefully you will be able to hear. Can you hear that?
It isn't audible.
It is inaudible? Okay, there is a switch. I'm going to stop sharing. There's a switch because I do have other videos, and then I'm going to share again with the, I know there's an audio, something that I'm supposed to click. Oh, here we go, share sound, got it. And optimize video. Thank you for your patience. I'm going to try that again. Now it should be come through. Okay.
Individuals who have alcohol use disorders is an incredibly important population to focus on, and
Oh, sorry.
Individuals who have alcohol use disorders is an incredibly important population to focus on, and there has been a lot of efforts in that way, and we still need to do more. I am particularly worried for individuals that are drinking, maybe in regular fashion, but they're more drinking to cope. And so I think it's really important that we focus on just drinking in general for people that we think are distressed or tell us that they're distressed, and use that, not just say don't drink, but ask them why. Ask them why they drink, and then try to get them brainstorm, make this a collaborative process of some other things that they can do when they, instead of drinking in that moment, that serves the same function.
So that's probably something that all of you know about, but what we don't often know about is the connection between drinking, between substance use, and suicide. And so I'm going to talk a little bit about suicide, then I'm going to talk a little bit about the overlap between substance and suicide, and then I'm going to move into talking about warning signs and what you can do if you're worried about someone. So what are the contributors to suicidal behavior that I just showed you? This is just the same list, but now it's in a list form, so it's a little easier to see than in the bubble drawing. But what happens is that the person, they actually have a cognitive inflexibility to begin with, but when they're in a crisis situation, they have even greater cognitive inflexibility, which affects their decision making. So you might have heard that called a tunnel vision. And so what happens is in that crisis moment, they have difficulty problem solving. They have difficulty shifting gears. It's hard for them to see that there are other options. So they focus on the near-term rewards rather than long-term. You know, it's not going to get better today. They can't focus on the longer term. They have what I call a social emotional disconnection, but a DYS connection, a dysfunctional connection. It's not that they're disconnected from people, but their connection is not working for them, so that they might think, I love my family and my family loves me, but they'll be better off without me and I'm a burden to them. It's that illogical disconnection. There's a lot of love and feeling there, but it's not enough to keep them going. And then this sense of helplessness and hopelessness. So in a crisis, a person often doesn't have access to their usual coping. And this is why sometimes people say, I don't know, it came out of the blue. We had no indication. Sadly, when you look back after someone has taken their life, there are those indications, the risk factors and the warning signs, but we don't know to look for them. So that's one of the reasons I'm here today to talk about this. In terms of stressors, it could be their current mental health condition or a substance use condition. We know that often when people have these conditions, it's very distressing for them and it feels like it's out of their control. It could be a traumatic event, family conflict. Sometimes it's a humiliating experience or there's a feeling of humiliation. And in addition, for somebody who's already at risk for a variety of reasons, it could be exposure to suicide. So for instance, you might have heard in the media that when there's a lot of media reporting about a suicide, especially when there are details about it and when there's no information about messages of hope that can happen, the actual suicide rate in a population can go up. It could be in terms of recent losses. It could be losing a job, a relationship ending. These things can be feel very powerful, particularly for someone who they feel hopeless, that nothing's going to change, and they don't have access to their usual coping. There are also protective factors: resilience, social problem solving, feeling connected, social support. And when I say feeling connected, I want to add that when someone has that DYS connection, you can actually regain actual social connection by having a conversation with them. Spirituality is another protective factor, the willingness to participate in mental health care and the access to mental health care. So all these things can be mitigating a person's risk and vulnerability to suicide. The problem is that when somebody is in a crisis moment, their access to much of this disappears or is truncated. So these protective factors can break down in that moment. So what do we know about suicide and substance use? 65% of people who died by suicide who had an alcohol blood level taken were intoxicated at the time of their death. And almost a quarter of them can actually be diagnosed with alcohol use disorders. This is one of the largest risk factors that we know about in terms of suicide. There's no other factor except at least a factor that can be altered that is so associated with suicide. Almost a quarter of people had opioids in their bloods. About a quarter of people had antidepressants in their bloods, which really means that many people were not being treated. And research has shown that even that 24%, most of them were under-medicated. So there's a lot of speculation about what is the overlap between, especially opioids and suicide, because it can be in your system, or it can be a means of death. And sometimes we really can't tell the difference, but many times we can. And that comes from gathering a history. And now we have the National Violence Death Reporting System, where at the time of a suicide or homicide, they gather information from the medical records, the police records, and hospital and the coroner's records. Unfortunately, we don't yet include all the family history and family information and information from friends. So it's a limited record, but it's better than nothing. You can see that in most recent data for suicide and substance use, which is 2022, the rates are, the rate of drug overdose death was twice as much as the suicide death, but you can see that we know about the opioid crisis, we know about the fentanyl crisis, so that kind of, it's very sad, and we've lost a lot of people, but it also changes the comparative data between suicide and substance use. So you can see that before that crisis, the rate of death from substances was still higher than that of suicide, but the big discrepancy was not there. Interestingly, substance use disorders were associated with increased relative risk for suicide for both men and women across all categories, but the relative risk was more pronounced in women. And this is interesting because men die by suicide 3.85 times as often as women. And so if there's something that increases the likelihood of suicide, we want to understand it, and we want to use that information to try and intervene and prevent suicide. In terms of the overlap between deaths by suicide and substances, interestingly, opioid-involved deaths that were opioid suicides were more people who died by suicide with opioids were tended to be younger. Well, 18 to 64 is a pretty broad range, but when you see the next item, you'll see that it's different. They tended to be white, non-Hispanic whites, and they tended to be unemployed or disabled. That's looking at opioid suicides versus non-opioid suicides. When you look at opioid-involved suicides versus accidental suicides, accidental deaths, non-suicides, you actually find that that group is more female, that though they're younger, they're whites, and they're employed, which is a different group of people. And then if you look at all the suicides that involve opioids, 45% involved other substances. So I'm sure you know that the issue of polysubstance use is a big one, and it clearly contributes to suicide by people with substance use disorder. But it's not a unitary group. There's a few studies that have engaged in latent class analysis and are trying to find out, is it just substance use or is there something different? And interestingly, they've come up with several different groups of people where they're at, these are people who died by suicide. The biggest group are people who had mental health conditions. And the next biggest group is people who had mental health conditions and substance use disorder. Then there's a group of people who died by suicide who had substance use disorder with no other known mental health conditions. And I'm emphasizing the known because that doesn't mean they didn't have it. It just means it wasn't recorded in the death registry. And then the last group was a group that had no known mental health disorders, but physical health disorders. So this is likely the group of people who died with opioid use. So you can see it's not unitary. You can't just say that all people who use substances aren't at increased risk. just like you can't say all of anybody is or isn't at risk. So what are the warning signs for suicide? And these cut across. I'm going to share this video of people who actually made suicide attempts, and they're talking about what happened before their attempt. These people clearly all survived, and most of them are working in the field of suicide prevention.
I wanted to hold everything and hold it all together for everyone else while I was literally dying on the inside.
Wasn't sleeping, didn't want to go out, didn't want to leave the house, self-medicating. In fact, thinking that, family would be better off without me.
I started pushing away from people that were there and supportive of me. Blowing things off that I used to enjoy doing, just kind of going to my room and just staying there.
I was cutting, I was harming myself, and just alone, just very alone and isolated.
I began to say goodbye in subtle ways, letting my parents know that they've done a good job raising me. I began to engage in a lot of drinking alcohol, smoking marijuana, just really trying to hide myself from all the pain.
I was withdrawn. I was angry to everybody, my family, friends, teachers at school.
I slept a lot. I had a tough time. I lost a lot of weight. Then I would go into manic states where I just was completely out of control. I was drinking a lot. I was abusing substances. And it was just a very horrific period of time for those who loved me, my family, friends that saw me change like that. It is pain. It is actual physical and emotional pain that you're feeling. And it's to the point where I decided I no longer wanted to live.
So that experience of pain is something that many people talk about when they survive a suicide attempt. It's not necessarily that they want to die. They just want the pain to stop. And so when we talk about warning signs, it doesn't mean that right before they engage in suicidal behavior, that they suddenly start showing all these things. It's much more subtle than that. Like the gentleman who said, I began telling my parents that they did a good job in giving things away. So it's what we hear, what they say, what they do, and how they feel. But this could come up, even a year or two before. That moment when they actually take their life can be out of the blue. But there are often warning signs if we look for them. And it's very hard when someone loses someone to suicide and they didn't know that there were warning signs. Not that they could necessarily have stopped it, just like other health conditions. Think about heart disease. 550,000 people died of heart disease last year. Many of them tried and were able to stay alive, and some of them tried and they still weren't able to stay alive. And then some people didn't try or didn't even know they were at risk. So it's a similar thing for suicide. It is a health condition. We try our best. Unfortunately, we can't save every life, but we can. I think of it as one person, one moment at a time. So when I talk about these warning signs, which you can see, all the things that they mentioned in the video are the things that we know from the literature. And change in use of alcohol or drugs is a big one. So people will talk about feeling like a burden, feeling trapped, feeling like they can't go on. But it could be subtle, like, oh, next year you won't have to worry about me. Next week, everything's going to be different. There's also the things they do. So increased drinking and drug use, isolating from friends, sleep changes, both more sleep or less sleep. And insomnia is a hallmark warning sign. And you definitely want to check in with people if they are experiencing insomnia. And, while we think of people who take their lives as depressed, and that about 60% are, there are other kinds of moods that people have, either overlapping, interchangeable, or just taking them over. So loss of interest, rage, irritability, which often goes along with both bipolar disorder and with substance use. Humiliation, which, by the way, is another factor that many people with substance use feel humiliation because they know it's affecting them, but they can't stop it. Also, anxiety and hopelessness. And like I mentioned, in that moment, they can't think of anything else. They can't shift gears, and they just feel a lot of pain and feel like they're never going to be able to escape it, and that the only thing is to take their life. Decision-making is changed and compromised in that moment. They feel that disconnection, their sense of purpose is diminished. And like I said, their intention is to end the inescapable pain. And by the way, these come from cognitive studies as well as qualitative studies talking with people who've made suicide attempts. So during that crisis period, there's what we call a risk arch. So the risk increases and then it peaks. And then if you get through that period, which can be just moments, you're likely to survive and not die by suicide. So what can you do if you're worried about someone? So 4 things you can do. 1 is watch for warning signs. We want to turn hindsight into foresight. We want to watch the people we care about and pay attention to their sleep, their appetite, their socialization, their thinking. Are they getting stuck? We want to reach out and have a conversation, which I'm going to talk about. Make sure the environment that they're in is safe. So if they do act on it, they will stay alive, and try to help connect them with care and resources. What you're not going to do is suddenly become a mental health professional. What you can do is tell people that you care about them and you will help them get through this terrible, painful period. Without judgment, just have a conversation or 2 or 3 or as many as you need. So how do you start that conversation? It can be very friendly, very chatty. You take someone to a private place. You don't want to do this across the dinner table or in a classroom or at work. You might, over a cup of coffee, say, I noticed you're not going out with friends as much, or you're sleeping a lot more. I'm worried about you and wondering what's going on and if I can help in any way. Or you could say, you're really important to me. I care about you and you don't seem like yourself lately. I'm wondering if something's happening that's stressing you out. That starts the conversation. And then something like, with everything that's going on, wherever it is, work, home, school, girlfriend, boyfriend, I'm wondering how you're feeling. And I'm wondering how you're doing. And I thought I'd check in. So you don't have to start with, are you thinking of killing yourself? You want to open the door and let them know what you see that's different. Let them know you care about them and that you want to hear what they have to say. So you want to ask open-ended questions, show empathy and support, and listen for those warning signs. The important thing is to avoid judgment, avoid saying things like, what are you worried about? This will pass, or you have nothing to worry about, but really listen to them and let them know you hear them. So if you ask them, I've been wondering, sometimes people, when they feel this way, they might think about taking their life or killing themselves. Have you thought about that? I want to know what's going on with you. So then you can ask questions like, how has that made you feel? I'm here for you. Sounds like you're feeling, and whatever it sounds like they're feeling, repeat it back to them. It sounds hard. And I want to make sure that you're okay and you're safe so that you can get through this period. And I'm here to talk with you about it and listen. Let me know what you need. And if you're not the person that they would talk to about it, say, I'm worried about you. Have you spoken with whoever it is that they are close with, your parents, your friend, your partner, or you don't have to be the one. You just want to make sure they're talking to somebody. So you want to listen without judgment. You want to ask, how can I help you? Let them know you care, validate their feelings. And unless they ask you how to fix it, just try to listen. And it's okay to even say, I know I want to fix this for you, but it has to come from you. So just tell me what's going on. And together we'll get through it. It's hard. It's a little bit scary sometimes. I've been a therapist for almost 40 years. It's still, you don't want somebody to want to take their life. So you don't want them to be feeling that way. But if they are, you have to be non-judgmental and be there and listen to them. Don't interrupt them. Don't tell them what to feel. Don't make them speak. Sometimes, a lot of times people say, oh, I'm fine, nothing. Or it's all my fault, or I screwed up. And just let them say it and try not to reinforce that. Just tell me what you're feeling. Let's talk about it. What happened? After the conversation, whether they told you something or they just said, no, I'm fine, follow up with them. I'm glad we had coffee the other day, and that you told me about how you're feeling. How are you doing? Have you found someone to talk with? Or you told me you were fine. I just want to check in because I'm still worried about you, even though you told me you're fine. So eventually, if they don't talk to you, they may talk to somebody else. So based on the conversation, it's not like you have to jump into action. It doesn't mean that it's an emergency. It's about helping them to get help. If it is an emergency and somebody is in the process of making a suicide attempt, you can, if they're actually doing something in the moment, you do want to call 911. But many times in a crisis, you can call 988 or you can help them call 988, which is the mental health and suicide crisis line. Just 988, you can call it, text it, go online, and there's someone there who's trained who can help you or the person. They can advise you what to do, or they could speak with the person. 80% of people who talk to 988 say they feel better when the conversation's over. And most of those people say they're not thinking about suicide anymore. And sometimes they'll work with you about calling mobile crisis. And it's a very rare case where they would actually call somebody to come and rescue you, because usually it's de-escalated and the person can then get out of that crisis moment and start planning on how to take care of things. But also take care of yourself. It can be very scary. You might be worried. So talk to your friends and family and make sure that you take care of yourself. We have a great program called Seize the Awkward. It's meant for 16 to 22-year-olds, but honestly, it has great ideas for everyone about how to have conversations. So one very important thing, and this is particularly true when people are using potentially lethal substances, is to limit access to the lethal means. And people don't realize that you can actually save a life by limiting access to lethal means, because you make it inaccessible. And in that time, it gives you time for things to de-escalate, time for somebody to intervene. Let's say you're not there, but they can't find what they're looking for. That's time where somebody might show up. And if they do make a suicide attempt, they're more likely to survive because they will not be using something lethal. So it helps the person stay alive through a crisis so that they can develop the life that they would like. And there's something called a safety plan. I'm not going to go into that today, but it's a really helpful plan for those suicidal crises to figure out what you can do first on your own or with someone else, or who you can talk to, professionals you can call. And it also includes how to limit access to lethal means. You don't have to do that to a person. You could ask them, what would help keep your environment safe while you're feeling this way? And locking them up or removing them from the home are the best possible things you could do. Locking them if you can't remove them. If it's a firearm, there's a great website called Lock to Live that a person can use to make their own decision about whether or not they should lock up their guns or remove them from the site. And you can just Google safe gun storage map, and it'll come up for anywhere in the country. Storing guns unloaded and locked is the best way to store them, and medications and other toxic means in a lockbox. Even if they're over-the-counter meds, they should be locked up. Encourage people to avoid substances during the time of more impulsive moments and potentially suicidal moods, and encourage them to keep their environment safe by talking to the other professionals in their life as well. Try to connect them with care. We have a great website with all kinds of possibilities for treatment, and we have for specific cultural and ethnic groups, as well as more general places. Ask the primary care clinician for referral, contact your insurance company. They can tell you who's available. I'm not going to say it's easy to get help. It's not easy to get help, but there is help available. And you can do, if you have somebody you're worried about, helping them get help is just an incredible thing for you to do, because treatment works, whether it's therapy or medication and therapy, whether it's start with the short term and what the longer term options are, inpatient, outpatient, partial hospitalization. And I think I'm going to skip this video. And there are all kinds of prevention approaches, particularly when there's substance use involved. But we do have to address the substance use and the mental health, other mental health issues and suicidal behavior directly. Through, I think I have it here, that medication therapy for substance use actually works. And in terms of reducing the suicide rate, doesn't eliminate it. I wish we could, but it reduces it. And even for people who started medication assisted therapy and then stop it, they're more likely to stay alive and not die by suicide. Treatment needs to include addressing the substance use. And for people who have heavy substance use and a suicide attempt, it's best to start with inpatient treatment and then develop an extended care plan. We funded a study that looked at cognitive behavior therapy in an inpatient setting. And what they found is that they reduced suicide attempts by 60% over 6 months relative to people who didn't have it. And they also reduced psychiatric admissions, except for people with substance use disorder. So people with substance use disorder did reduce their suicidal behavior, but they might still end up in the hospital for treatment. So like I said, we must address substance use and suicide together to save lives and bring hope. I just want to say, please take care of yourself. It's really critical. Short-term, in-the-moment stress reduction, breathing is highly portable. Everybody can do it. And then take care of your mind. There are many activities you can do to take care of your mind, your body, and your soul, and your environment. Creating nice places where you feel better. Virtual gatherings, watching something that you like. So please take care of yourself, and I'm going to stop sharing.